Thank you very much for the kind introduction, and thank you again for the invitation to those incredible rounds that, to be honest, you should be very proud of. So with no further delay, today, I think that's an important lecture that I'd like to actually discuss with my fellows when I have them in the OR, and then with my residents and colleagues, because we all struggle a little bit with this assessment of aortic stenosis. And I think LVOT obstruction is part of the differential diagnosis too, and I think I would like to include it in this lecture. So I have no disclosures for this talk. Today we are going to try to talk a little bit about aortic stenosis. We are going to talk about the different types that we have based on the anatomy, and how, after all those years, what are like the pearls that I think everyone should have when we are assessing an aortic stenotic valve. And then we are going to go at the very end of the lecture with dynamic LVOT obstruction. So those are the learning objectives. The only thing I can promise to the audience is I will try to actually reduce as maximum to my measurements. I'm going to try to give them a clear logic of why we do this when we are, especially for us in transesophageal, right? And then what are the safer hemodynamic decisions that we need to make in those patients. So for us, as anesthesiologists, again, when we assess aortic stenosis, all the guidelines mostly refer to transthoracic, and we need to actually adapt to that, right? We have several transesophageal guides, but when we actually read about the aortic stenosis guidelines in the American Society of Echo, and when we have it the European guidelines, they are all based in transthoracic, right? So for us, it's very important because first we need to know what's abnormal with this valve, and then we need to know physiology and if I'm treating it right. So for us, the main important problem that we are going to find is when we are quantifying aortic stenosis severity is going to depend on the flow, on the rhythm, on the blood pressure, and on the measurement quality. So first, we don't have the right cool. We have transesophageal echo when the gold standard is transthoracic for the gradients and the velocity on the valve. The flow is going to be diminished because we have a patient that has been fasting for 7-8 hours. Rhythm, we are going to have rhythm issues when we have heart manipulations from the surgeons, and the blood pressure is going to be all over the place when we are actually under general anesthetic. So that's what we're going to try to address today. So first, aortic stenosis. So the recommendations from the 2025 guidelines are very clear, right? So you need to do something integrated and not an isolated measurement. As an example, you have on the right-hand side, several velocities and mean gradients that are not matching severity when the aortic valve area is matching severity, but the exit aortic valve area is not matching severity, and we have a stroke volume. What are we going to do with those, right? So I think when you read the guidelines, my recommendation will be, first of the things, verify that the data that you are acquiring is appropriate. So verify your LVOT. The LVOT is an important source of error. And then verify, if you can, multiple windows and multiple Dopplers occurrence to actually check that this is actually appropriate. Then look at the flow state. We normally have a threshold, and your stroke volume indexed should be more than 35 mL per meters to the square before making a decision. And then when there is discordance on echo, then the calcium from the CT score is what is going to help most of the time to actually adjudicate that discordance, right? Extremely important. What are the symptoms of our patients, and what are we going to do with this patient afterwards? So we are going to start straight. So pure anatomy. The two views that we use in transesophageal echo are going to be on the left-hand side of the screen, your short axis view of the aortic valve between 30-45 degrees, and then the long axis view of the aortic valve at around 135 degrees, right? So the short axis view is the one that is going to give you the map to the cusp on your aortic valve. Non-coronary cusp is always going to be associated with the intra-atrial septum. The right coronary cusp in between the tricuspid and the pulmonary valve, and the left coronary cusp facing up to the left atrium. When we go to the long axis view, we need to know exactly where are we cutting that valve. The recommendation from the guidelines is to go from the right coronary cusp up to the junction between the non-coronary cusp and the left coronary cusp. If you have like a multiplane modality, even you use depending on the platform that you are using, it would be ideal to go to the short axis view and look for exactly that spot. And that's from there is where you actually can increase your angle and go to 135, or even in the same multiplane view, that's where you want to actually have your long axis view looking into the aortic valve. So etiology. So for etiology, we always say this is morphology is not decorative, right? So we have acquired aortic stenosis that can be rheumatic. Normally, we look for a triangular systolic orifice or calcific when it's like more an stellate-shaped systolic orifice. And then we have congenital. The most common one is bicuspid, but we have other ones like unicuspid, very unlikely, and quadricuspid too. So those are the majority of the times that we are going to be seeing like the morphology of an aortic stenosis. So if we go to the unicuspid, because we are not so used to actually see this type of valve, it's only on 0.02% of the adult population. And I think the two common characteristics of the unicuspid aortic valve is that there is a single commissural zone of attachment, and there is an eccentric valve orifice during systole. The difference between acommissural and unicommissural normally happens after the third, fifth decade of life, and you have the presence of a lateral attachment to the aorta at the level of the orifice, something that doesn't happen in the acommissural. The acommissural looks like it's floating inside of the aorta. As an example, we have this here. We have a single commissural zone of attachment. We have an eccentric valvular orifice during systole. And if you want to know which type of unicuspid valve this is, so we have the presence of lateral attachment. So unicuspid, unicommissural, and that's the one that we actually got in this case that was confirmed after the surgeon took the specimen out. Okay, if we go to the most frequent one for congenital, that's going to be your bicuspid aortic valve. We started with the Sievers classification back in 2007. They describe it between type 0, type 1, type 2, depending on the numbers of raphies. It's based on a surgical specimen classification. Then we go to type 1 when there is no raphy, type 2 when you only have one type of raphy, and then this is an example of I2 with two types of raphies. Then 1 year later, like Schaefer's, one of the prestigious aortic valve surgeons from Germany actually came here and then told us that he wanted to do a different classification based on the clinical phenotype. So then he described this as type 1 when they have a right to left commissural fusion, type 2 when you have right to non, and type 3 when you have left to non-coronary. The most common one is right to left. This is an example. This is the orifice opening. This is the non-coronary cusp, the left, and you can see the roughing between the left and right coronary cusp, which is the most type 1 and the most typical clinical phenotype. And then finally, in 2021, we have an international consensus that recognizes like 3 congenital bicuspid aortic types, and that's what we should actually, I think, import to our reports. So the first one is the fuse type. So basically, it's telling you that you have a raphy, and then you need to describe which are the cusps that are actually having the raphy, right? Right or left, right or none, left or none. The second type is the 2 sinus type, which looks like purely like a perfect bicuspid, which is lateral-lateral or anterior-posterior. And then the last one, which is a little bit more difficult to diagnose because it may look like a tricuspid valve, is the partial fusion. That's the one that has a tiny raphy, and then you can see up the stream, so the valve is not fully open. So this is real cases of congenital bicuspid aortic valve. In this case, you will have the right to left cusp function. And then, as you can see here from the short axis view, you have the multiplane that allows you to see the same image at 90 degrees, one from the other. Is ideal to actually see where you are cutting and see the valve in a better manner. The other thing that we can do to actually get a little bit of a better approach to anatomy is to use like 3D echo. And then sometimes it may be challenging because you have a lot of calcium, but if you know how to crop the valve, decrease a little bit your gain, and then optimize your image, it can actually give you a very good idea of what's going on with that valve. Okay, so now we know our anatomy, so now we are going to go one step ahead, and then what do we need to actually like quantify aortic stenosis? So basically, we need like three separate measurements. First, we need to get the LVOT diameter. This is actually acquired in transesophageal from the mid-esophageal aortic valve long axis. The recommendation from the guidelines is to do it between 0.3 to 1 centimeter below the aortic valve orifice, and you need to do it during mid-systole from inner edge to inner edge. Then we go to the deep transgastric view and we do the LVOT VTI with the pulse width Doppler. And you want to take that sample, and that's extremely important, at the same level where you measure your LVOT. So try to be accurate with that. Then you go with continuous with Doppler in the same spot. You try to find the maximal velocity. And again, remember, transesophageal is not the gold standard, transthoracic is. So you may undercall eccentric jets. You need to get the best window at the best alignment to actually get the highest velocity. And if it's not possible, you may actually need to use a pad of probe when this is discordant. So I think one of the most common sources of errors when we estimated aortic stenosis is going to be your LVOT diameter. So, and as I mentioned before, please be sure that you are measuring the proper cut. So when you go to the mesophageal long axis to measure your LVOT diameter, so you need to actually measure between the right coronary cusp and the connection between the non-coronary cusp and the left coronary cusp. So, and measure it, as we mentioned before, from inner edge to inner edge in mid-systole. When the LVOT is elliptical or calcified is when 3D TE or CT planimetry can actually reduce the underestimation, right? In our case, the thing that we can do here is actually advocate for a 3D TE. Again, one of the most important discussions is a lot of people is mentioning, okay, from 0.3 to 0.1 centimeters in the aortic valve orifice or at the annulus in severe calcified AS. So which one is actually the measurement? Where do I need to take it? So there was a correspondence like between Bob Manter and Rebecca Hahn regarding this, and then some of the questions was, should we measure it when the valve is so calcified at the level of the annulus, which was the proposal from Dr. Hahn, right? And then the answer basically is like the LVOT diameter measurement should be performed at the same level as the LVOT velocity recording. As soon as you get that, that's what the most accurate measurements on quantifying aortic stenosis are going to happen. Okay, this is an example of an LVOT diameter of 2.3 measured by 2D. Then we do the LVOT VTI, and we do the aortic valve VTI with the continuous with Doppler. We got an aortic valve area of 1.33 centimeters to the square, which will be in the range of moderate aortic stenosis, right? So as we know by the guidelines, we can actually use 3D. So how can we use 3D? So to give you an example here, so you do 3D of the LVOT. You measure your diameter. In this case, instead of being 2.3, it was 2.02, right? It gives you an area by direct planimetry on the LVOT, right? And the area is 3.2, and that's equivalent to an estimated aortic valve area of 0.8, which is different from 0.133. So that's how 3D can help you in those situations. Okay, next step. So once we have sorted out how to measure the LVOT diameter, now we need to actually get the Doppler alignment and get the highest clean signal is the one that is going to win. Recommendations from the guideline, important, the time axis, which is at the lower part of the screen, should be always between 50 to 100 millimeters per second. And you want to actually have, you want the wall filter that you can see on the left-hand side of the screen okay? And you need to actually adapt the wall filter to display the start and end of the flow signal of interest. And you need to trace like the dense and physiological signal, not the noise, not the aliasing, and not the spectral broadening or another jet. So when we are doing the LVOT push-bed Doppler sample, again, measure at the same anatomic level as the LVOT, at the LVOT diameter, right? So one of the recommended views is the deep transgastric view, because you can align very well with your aortic valve. And then what you need to remember is to set your low wall filter setting, and that's the equivalent to your apical, to your 5 chambers in transthoracic. So when we do that, just remember to actually keep the sweep speed between 50 and 100. And then if it's too much flow acceleration, remember that you can always go a little bit back to actually avoid having problem when you are measuring your velocity. The alternative option that we have in transesophageal is the transgastric long axis view, around 100, 110 degrees, but then the angle is going to be a little bit not perfectly aligned as the other was, but sometimes when you can get the deep transgastric is the only option that we are left with. Okay, when we use continuous wave Doppler for the AS jet velocity, right? So you want first, the advantage of doing this is a direct measurement of the velocity, is the strong predictor of critical outcomes. But the limitation that we have with this is that you require a parallel alignment of the ultrasound beam, and sometimes this doesn't happen. Again, remember, as recommended by the guidelines, the BTI should be traced from outer edge of the dense signal. And the report window where you need to actually go and report it where the maximum velocity was obtained. And again, remember, this is going to be flow dependent. The double envelope technique is something that you can use. And the beauty of this technique is that you can simultaneously obtain the left ventricular outflow tract and the aortic valve velocities in a single beat. The problem with this technique is you are going to overestimate the peak and overestimate the aortic valve area. So the best recommendations from the guidelines is to do pulse width Doppler for the LVOT and continuous width Doppler for the Vmax of the aortic valve. As a level 2 alternate, we have the velocity ratio. So when is the velocity ratio helpful? Velocity ratio is basically the velocity in the LVOT divided by the velocity in the aortic valve. In normal conditions, the velocity in the LVOT should never be 25% of the total velocity in the aortic valve. When it's 25% or less, that means a DBI of less than 0.25, and that's significant for an aortic valve area of less than 1. You can actually use this when the LVOT diameter is uncertain or you are underestimated and there is less variable continuity aortic valve, and we ignore the true LVOT variability. So another option is to do planimetry of the aortic valve area. It can be useful, but it's a level 2 alternate. It's an anatomical aortic valve area. And why is that? Most of the times inaccurate, because sometimes you will have like severe calcification, you will have shadows and reverberations, and you're going to have a limitation of to identify the orifice, right? Another good thing that can be actually used in the mid-esophageal aortic valve long axis view, you can actually have separation of the cusp with a mode, and then where they are less than 8 millimeters, that's significant for an aortic valve area of less than 1 centimeter to the square. So the 3 primary hemodynamic numbers that we are going to be looking when we quantify aortic stenosis is a peak velocity of more than 4 meters per second, a mean gradient of more than 40 millimeters of mercury, and aortic valve area less than 1 centimeter to the square. We are all very familiar with these recommendations for grading AS. And then indexed valve area less than 0.6, and the velocity ratio that we just commented on 0.25. So up to here, there is no problem. We all do it in the echo lab or in the OR, but then the problem is when you don't have a concordant aortic stenosis. So when you have a concordant high gradient severe AS, very straightforward. Velocity more than 4, mean gradient more than 40, aortic valve area less than 1, or indexed less than 0.6. That's it. So if you have a high Vmax and a mean gradient are high, stop searching for low gradient AS, right? Um, so the problem comes when we have discordant aortic stenosis. So for discordant aortic stenosis, you're going to have, and you're going to look for, is there a problem in my LVOT diameter, in my BTI in the LVOT, my sample size? Was there a problem with my continuous wave Doppler? Like, did I use multi-windows? Did I use the highest velocity? And then I'm going to check my hemodynamics, right? Especially in the OR. What was my blood pressure when I was taking this? What was my rhythm? What was my heart rate? What was my flow state, right? Then morphology, specifically how much calcification is in this valve, how much it's opening. That makes sense with the measurements that we are taking. And then I'm going to decide based on all those characteristics, if I can decide, maybe the CT calcium score is the one that is going to help me. So we are going to comment now for discordance phenotypes. So which is going to be low flow, low gradient with reduce and preserve LVEF, and normal flow, low gradient with preserved LVF, and high gradient AS when the aortic valve it's more than 1 centimeter to the square. So when you have a low flow, low gradient aortic stenosis with reduced ejection fraction is defined, reduced is defined by the guidelines less than 50%, and low flow is going to be defined as stroke volume indexed less than 35 milliliters per meters to the square. And we say that is low gradient because your Bmax is less than 4 or your mean is less than 40. So the option that we have, because the ejection fraction is low, is to use a low dose of the dobutamine stress test. So when we use that, we aim for an increase in the flow reserve for more than 20% in the stroke volume. And if then the aortic valve area remains less than 1 centimeter to the square, this is a true severe aortic stenosis. If, despite that, the aortic valve area increases more than 1 centimeter to the square with the flow augmentation, then we call it pseudo-severe. If we can achieve this increase in flow reserve of at least 20%, then the calcium score is going to give us the final diagnosis, right? And then we say supportive of a severe AS is when it's more than 2,000 AU in men and more than 1,200 AU in women. On the other hand, when you have a preserved LVF, but you have low flow, low gradient, that means low flow, again, stroke volume indexed less than 35, and low gradient, Bmax less than 4 or mean less than 40, then we need to be sure that we are measuring this when the patient is normotensive. We want a systolic blood pressure of less than 140 millimeters of mercury. And we need to look for, like, if you have a very small LV size and very hypertrophy with concentric remodeling, this can give you that. And then you can use the dimensionless index or the CT calcium score to decide in between one versus the other. Okay, now we have a normal flow. That means the stroke volume is indexed, is more than 35 millimeters per meter to the square. We still have an aortic valve area less than 1, and we have a normal ejection fraction. But the maximum velocity or the mean gradient is less than 40. So the default interpretation for this, and my recommendation is to call it moderate AS, unless there is full like clinical and picture that says otherwise. But then you want to definitely recheck with this. Is my LVOT diameter taken appropriately? Was my pulse width Doppler in the LVOT exactly measured at the level of the LVOT diameter? Was I able to get the highest Bmax from all the windows? How much was my blood pressure? Was the patient bradycardic? Was there a prolonged ejection time, right? And then what was my calcium score? Those are things that can actually help you to make the final diagnosis here. So basically, the take message for this discordant aortic stenosis is that when echo is discordant, the CT calcium score is going to be your referee, right? Like you are going to say like severe likely when you have more than 2,000 AU in men and more than 1,200 AU in women, okay? So when we have aortic stenosis, one of the questions is intervention, right? Why do we need to operate? And then as you can see in this graph, like the survival after the 60s gets dramatically reduced, right? So if you have symptoms that are attributable to the aortic stenosis, then we are going to look for intervention. If you have a low EF, the prognosis is not going to be good. And if there is the low EF is due to your aortic stenosis, that is actually aiming for an intervention, right? If you have an asymptomatic high gradient severe aortic stenosis and it has low procedural risk, you can consider it. And if you have markers that support this, like very severe AS, rapid Vmax progression, severe calcification, and all these are going to actually give you an idea that we need to act in this valve. Of course, not only like surgically, but also with the transaortic valve replacement, right? An important thing that we take from the guidelines is like the best predictor for prognostic markers is the peak aortic velocity, especially when it's more than 5.5. When the velocity, the transvalvular velocity is increasing more than 0.3 meters per second per year, and when the increase of the mean pressure gradient with exercise goes more than 20 mils per mercury. Those are things that are going to help us make that decision too. So we know severe AS is a fixed outflow lesion until proven otherwise. So in these patients, we want to avoid hypotension. We want to avoid tachycardia. We normally say our ideal heart rate is going to be between 40 and 60. You don't want to go to bradycardia because then you are going to compromise the preload too, right? We want to maintain the preload. So those patients that they come, they are 8 hours fasting, so no fluid. So normally we give them a little bolus. And then we need to treat vasodilation early because you have a hypertrophic heart. And then if you underperfuse that heart, you are at high risk of ischemia too. Okay, that was the part for the aortic stenosis. So now we are going to go to the next section of the lecture, right? So not all gradients are valvular. Like you have late peaking Doppler, you have systolic anterior motion of the mitral valve, you can have a small LVOT, hypovolemic, high catecholamine tone. Everything can change the pattern, right? So when we talk about LVOT obstruction, so I think the first thing is try to differentiate this from your standard aortic stenosis patient. When you have aortic stenosis, you have valvular aortic stenosis. So you're going to have a fixed obstruction. There is going to be a delay acceleration time. It's going to be more symmetric envelope. The peak often is early to mid systole. But then when you have something completely different, right? You have a late peaking, dagger shape, shark tooth, velocity accelerates through systole, right? And then at the end you have this. When you have those type of Doppler spectrums, that's when we need to look about for LVOT obstruction. Always remember when we are doing this to exclude MR contamination when tracing a high velocity systolic jet. So dynamic LVOT normally it's normally started with a small LV size cavity by hypertrophy or by hypovolemia. Then these may induce SAM, especially when you have like a systolic hypertrophy on the septum. And then you start to get an LVOT gradient. Then with the LVOT gradient, you start to get MR and you start to get less flow that goes forward. Then you increase your catecholamines, and then is when you actually put the patient in danger, right? So things that are going to trigger your dynamic LVOT obstructions in, for example, not only patients that they have some degree of LVH, right? Is those patients that have like hypertension and they have concentric LVH, and then they are hypovolemic, they are vasodilated, they go to tachycardia, they are anemic, you are using high doses of inotropes, and then there is like suddenly an afterload reduction. So all those things that we read there, it's exactly what happened when we do an induction for any of our patients, right? When we put them through sleep. So we are going to check this based on a clinical case that we have maybe a couple of, I would say 4 months ago. So this is a 67-year-old male. Is a postoperative day 15 after a liver resection. The patient was in septic shock from a biliary leak, and there was an emergency laparotomy for source control, right? So the patient was booked to the OR. When one of my colleagues went to assess the patient into the ICU, the patient was intubated, people fate, FiO2 of 80%, hemoglobin was low, 72, the lactate was already 22, the blood pressure was low, 81/44, and the patient was tachycardic. The patient was in norepi, dobutamine, epinephrine, vasopressin, and in LNO. Try to decrease the flow into the liver after a liver resection, right? But to be honest, at that time, we were wondering, why do we need so many pressors? And the first question is this patient in septic shock? Is this patient having any positive cultures? And all the cultures were negative. The patient didn't have any positive cultures, right? So the question here is this vasoplegia? Is this septic? Is a cardio? Is like a problem or is something that we can really treat? So before bringing the patient to the OR, because the emergency laparotomy was to see maybe something that we are not seeing, right, in the cultures. So we went in and we decided to do a TE. And again, that's what we saw. And as you can see on the left-hand side, we have a 4-chamber view of the mid-esophageal 4-chamber view. And then on the right-hand side, you have the mid-esophageal long axis view of the aortic valve. As you can see, this is a very, very reduced LV cavity, hypertrophic LV. And then you can see perfectly fine how the anterior mitral leaflet is actually going into the LVOT during systole, right? So when you see that, and then you put some color on, so what you can see is flow acceleration through the LVOT and posteriorly directed mitral regurgitation, right? Which is a clear sign of systolic anterior motion of the mitral valve causing LVOT obstruction, right? So here we have other views, and then you can really see this mitral valve moving into the LVOT, and how when that happens, the coaptation of the mitral valve, the anterior leaflet with the posterior leaflet gets open, and then you have the posteriorly directed jet, right? So we did this, and as you can see here, instead of having like a typical aortic stenosis pattern, it's a late peaking, right? So this is basically SAM, a small hyperdynamic LV, and late peaking continues with Doppler, right? So this is not septic cardiomyopathy, this is not vasoplegia alone, right? There is something else going on, right? So at that time, the question is, and the question that I asked the audience is, based on the TE images, what would be your next step in the management, right? So one of the things, if you go blind here, you may decide to increase the epinephrine because the pressure is only 80/40. You don't want to do that. The lactate is already 22, right? You want to decrease the vasopressin because this is a liver, and then you are concerned that excessive vasoconstriction may cause a problem. You want to increase the NL and O. So to be honest, like here, we were not very sure why the patient was in NO. But then what we decided is to give a couple of units of red cells, hemoglobin from 70 went to 90, right? So we stopped the inotropes, and then we stopped the NO. And then after giving all these, right, and so the vitamin and the epinephrine and the NLNO were stopped, the norepinephrine was reduced to minimal doses, and the LVOT resolved on its own, right? And these are the images after 2 units of pack of red cells. So the norepi was reduced to 5 mics per minute, and the vasopressin was kept at 2. And as you can see here, we didn't need to do a laparotomy for this patient. We just needed like a better hemodynamic management of the patient. And that's the same view that we were seeing before. So the flow acceleration, it's gone. So you can see the anterior leaflet of the mitral valve is a little bit elongated compared to that, and the septum is pretty prominent. And those are things that are going to pose you in risk of SAM. And when we do, again, the tracing for the Doppler, right? It continues with Doppler, so we go back to a normal Doppler spectrum. So my final take-home message is T anatomy matters. So when you go for the valve, identify the phenotype before quantifying, so you can get a better idea on why is this valve stenotic. For aortic stenosis, again, the continuity equation is key, but again, remember Bmax and mean gradients are always going to be flow dependent. And when you have cases of discordant AS, you need to actually watch for your flow status, and you need to watch for your ejection fraction too, right? When we report like a congenital bicuspid aortic valves, again, remember that in 2021 we have a new classification, and that's the one that we should be using for us. And then dynamic LVOT is definitely something that we can treat. We can treat very fast, and then we can actually help the patient not actually being treating the patient blindly without knowing what's the problem with that patient. So up to here, as I promised, 40 minutes, I keep it there. And now is the time for the questions.